a consultant community psychiatrist in Oxford. I'm also chair of the World Association of Social Psychiatry Working Group on Coercion, but that's not what I'm here to talk about. But we're delighted to be sort of collaborating with you guys and looking at some of the issues. So I've been tasked to talk a little bit about some of the research that we've done in the social psychiatry group at the University of Oxford over the last sort of 7 or 8 years, which was funded by the NIHR, so by the Department of Health. There is a health warning. I mean, to go through it so quickly is rather superficial, and that's fine, but just to point out, there are flaws with the study. It has ended up being rather controversial, and if people have read it, they will have seen the criticisms also. So I can't go through all the flaws. I wish I could, but please do go and read about it if you want to know more. So we were faced with a question. Obviously, the government and society decided to amend the Mental Health Act very substantially in 2008, and it was due for an upgrade. And as part of that, new powers to compel people outside hospital for the first time were going to be brought in. And there's very little evidence to support that kind of move. So we ended up applying for this grant, and we were given the money. And immediately, it has to be said from our funders or from certain places, there were concerns about the fact that there was going to be a randomised controlled trial, because there were concerns about what the answer might be, and we'll come on to that in a minute. To put things in context, the evidence about compulsion in community settings is and was a mess. I think it's a bit less of a mess than it was, but it certainly still is a mess. The evidence for compulsion in inpatient settings is also a mess, but probably less so. And as previous speakers have said, now the overwhelming majority of care in rich countries like ours happens outside hospital. Sadly, that's not the case in most of the world, but that's a separate issue. And we really have very little evidence to guide us. So I'm going to talk a little bit about 2 things we did. One was looking at formal compulsion, and as importantly, but not as publicised, was some research that we did and that others have done looking at informal coercion. Manan was talking about it earlier on, which is, broadly speaking, the pressures that we bring to bear as professionals every day in our interactions with patients. And that can be anything from persuasion, encouragement, involving family to encourage people to do the right thing, which might be taking medication or coming to appointments. It might be in some way linking the receipt of benefits or housing to the acceptance of care. That's very common practice in North America. It's unthinkable formally here, but certainly patients' experience is that it happens quite a lot. It might be the threat of return to hospital if people don't cooperate with treatment plans, and all these kind of things. I haven't got a pointer, but just to very quickly, so we surveyed about 417 patients in our community services, deliberately across different areas of services, because we had a theory that people who were more ill, particularly people with psychosis, would experience very high levels of this kind of coercion, and people perhaps with depression and anxiety or substance misuse problems wouldn't, and how wrong we were. As you can see, if we just, to go over it very briefly, if you look at the second last column, then the pink people are the people in our assertive outreach services, the blue people are the people in our community mental health teams with the diagnosis of a psychotic illness, the green people are our people in community mental health teams with other difficulties, usually depression and anxiety, and the red group are people in substance misuse services, predominantly methadone clinics. And you can see that, and their percentages, so 2/3 of that last group felt that within the last year, they had experienced some form of coercion, some form of pressure. They didn't all say that was a bad thing. You know, and we did a lot of qualitative research underneath this, and people, you know, nearly 50% of people who had experienced coercion did say that actually, in hindsight, they didn't like it at the time, but it wasn't necessarily a bad thing. You know, their mum saying that they couldn't have access to their children unless they were having their methadone and testing negative for heroin, they didn't like, and it was coercive, but actually in hindsight, a year later, when that had been a powerful driver to them moving forwards and recovering, they were grateful it had been done. So it's a complex issue, but to be mindful that rates are very, very high. In terms of compulsion, so the use of legal measures to insist upon care and treatment, there was a very good systematic review about 10 years ago now by Rachel Churchill and colleagues, and they essentially concluded that there was no evidence, or that the evidence that there was so confused, of such poor quality and so messed up, that there really was no basis to use what it essentially is a legal therapeutic mechanism. The analogy to a drug, I think, is a very good one. We updated that a couple of years ago and found, again, that the evidence was a mess. So community treatment orders have been available for 50 years in some jurisdictions, mainly, again, in wealthy countries. And the evidence is very conflicted. There's some evidence that they're effective, but there's equal or more than equal evidence that they're not effective. So we wanted to do a quick trial. So we randomly sampled 300 and odd people from around the country, several from Cambridge and Peterborough, but mainly from the big urban centres of London, Birmingham, some from Manchester, to try and get a real mixture of people. And these were people who were detained under the Mental Health Act, who were leaving hospital after a period of treatment, and who were agreeable to taking part in the study, and their clinical teams were agreeable to them being randomised to either be made subject to a community treatment order or not. So they would leave hospital either, and this is putting it very superficially, to either leave hospital for fairly long-term compulsion or to leave hospital either as a voluntary patient or on very brief Section 17 leave, so a very brief period of compulsion. In terms of interpreting the results, we found that the two groups were very even, so the randomisation worked. We found that when we followed people up after a year, they'd had about the same levels of care, which is crucially important in analysing the results. So the patients in both groups had been seen about once every 2 weeks, and they were successful contacts. So quite a decent level, certainly in terms of international comparisons, quite a high level of care and contact, which is what you would hope and expect for with people who had been so unwell, because these were a very ill group of people. In terms of the level of compulsion, people who went on a community treatment order stayed on it for a median of 183 days. Consultant psychiatrists in the room will know why that is, because that's renewal day. And we're not lazy creatures, but that's obviously the day when you make the decision. And people who went either voluntarily or on very brief leave did, generally speaking, were informal recipients of care through the rest of the year. So we knew that any differences would be due to the use of compulsion, not the quality or the amount of care. And we found that, which very much upset quite a lot of people in this mental health community, and certainly upset a lot of people in political circles, because we found no difference. We didn't not find a difference, as some people have suggested. We found a very strong, very statistically significant no difference. The groups were identical. That's a very narrow measure, readmission to hospital, because not everyone would see that as a clear marker of illness or as a marker of failure, but it's all we've got in many ways. In terms of time to readmission, as you can see, there was no difference. People were sort of admitted back to hospital very gradually in both groups, which is what that curve shows. It's a survival curve. But there is no difference between the two groups. They had the same care and they did as well or as badly as each other. In terms of more important outcomes, so looking at things like levels of symptoms after 12 months or social functioning after 12 months, these are two very well-known scales. Again, there's no difference, really no difference. The other thing that these things show is that these people were really quite unwell and very challenged in terms of their ability to have relationships and manage practical affairs. That level on a global assessment of functioning is only just considered to be compatible with community tenure. And I think that was one of our most positive findings, was that actually in British mental health services, which are surprisingly to some of us the envy of the world, we do very well at maintaining and supporting people outside of hospital. So that's what we found at 12 months, and there's been an enormous amount of criticism, because our conclusion was fairly simple, that in well-functioning mental health services, and that is crucial, because in some parts of America they probably do work, because in New York State, for example, there's good evidence that being subject to compulsion helps you do better. But if you're not subject to compulsion, you don't get the same level of care. And we would say quite strongly that it's the level of care that matters, not whether it's legally mandated. So that's it, really. And if people want to have a look at the other stuff, then there's a website there.